Well, let me welcome everybody to Westminster Presbyterian Church. I don't even think I need this with this crowd as close as we are, and I don't need to have my back to these panelists either. We're really pleased to host this panel. It's been a conversation's been in the works for a while, and so we appreciate the work of the Adult Ministry Committee. And Randy, thank you for the leadership there and working with them. It's obviously you know better than I do in many cases the importance of this. And we hope that maybe our youth normally meet at 5. I'm kind of hoping some of them are going to be strolling in here before as we get started perhaps. But my name is Butch Sherrill. I'm one of the pastors, and I'm pleased to welcome our panelists and all of you who've come this evening for this special program. Thanks for being here.
And good evening. I'll just introduce myself. I'm Jim Donnelly, and I'm with the Adult Ministries Committee here at Westminster. Welcome folks here, as well as those who might be joining us online. We are going to start off today with a video. The statistics that you see in the video are a little bit dated, but I think the point will come across loud and clear. And after the video, I will introduce the folks on our panel.
North Carolina. Our state is such a beautiful place. But look closer. Closer. You might be surprised by what you see. There are millions of unused and leftover opioid pills in this state alone. And when you look closely, you start to see the problems, the misuse, the addiction, and the fact that opioid overdoses have doubled in the past 10 years. Almost 30 deaths every week. That's more than 5 every day. Oxy, Vicodin, Percocet, morphine. There are enough powerful opioid pills in North Carolina to stretch from the mountains to the beaches. And for many of us, the danger is right here at home, hiding in our own medicine cabinets. These unused and leftover pain pills are everywhere. They're overwhelming our state and devastating lives. But there is something more powerful than these pills, stronger than opioids. It's us, all of us. Together, we can take the first step in solving the problem. We can take back our unused and leftover pills. We can talk to our families about the risks associated with opioids. We can ask our doctors about alternatives for pain management. And together, we can overpower this deadly epidemic and take back our communities. To find a drop-off site near you or for resources and treatment in your area, visit morepowerfulnc.org. North Carolina.
What a nice introduction for us tonight. We are really privileged to have a panel of experts with us this evening who are going to be able to shed some light on this issue and hopefully help us learn about some ways that we can move forward together. First, I'd like to introduce on the far left of the panel, Jim Albright. He's the director of Guilford County Emergency Services, and among his many responsibilities include the oversight of EMS, and so he is there on the front lines of this issue and is seeing what's going on a daily and weekly basis. Next to him, Dr. Melissa Floyd Pickard. She is a professor at UNCG in the School of Social Work, and she brings a variety of clinical and research experience into this issue and is going to help us understand, in particular, family issues around substance abuse is one of her focus areas. Next to her, Mike Thule. He's the clinical program director at the Guilford County Solution to the Opioid Problem, which, if you may have heard the initiatives, GC Stop. That's his organization. And again, Mike brings with him a sense of clinical work as well as a variety of academic and other work in the community, again, to help us understand and tackle this issue. And finally, I'm really pleased, and as Butch suggested, Randy Abbott. He is a member of our congregation. He has a personal tragic story that brings him face to face in this, and he has embraced that and really become a leader in our community and the larger community on this issue. So we are going to have each of these panelists share a few thoughts. At the end of the rows, we have a couple of cards for you to fill out as the candidates are talking. Once we go through the presentations today, there's going to be an opportunity for Q&A. We've got a few questions that we've set up for our speakers, but want to give each of you the opportunity to ask what's on your mind. And so the yellow card that's in the row, and for every one of you, you should have a writing implement in front of you in the back of the pew. You can write your questions here, and we'll pick these up and go through those. The other item that we have is a white card, and that is just for us to get some feedback. Again, we really appreciate this opportunity to bring this to the community. We're going to be here again next week, but would welcome any comments or questions you have. And so with that, I would like to jump right into our conversation. And Jim, we're going to start with you. And when you're done, you can just pass it right off to Melissa.
Absolutely. So good afternoon. We're going to have a conversation a little bit around a crisis that I never intended to face in my medical career. I've been a paramedic now for 36 years and have dealt with substance use as part of my clinical practice for a long time, but never realized what was emerging as one of the greatest threats to our youth. And not just our youth, but something that impacts all age groups. So with that being said, next slide, please. I want to talk a little bit about the opioid crisis in America and take a little bit of responsibility of that as a person who administers narcotics to folks routinely in their clinical care. The U.S. is about 5% of the world's population, but in 2015, we prescribed 80% of all opioids worldwide. So I always tell people I'm a person of science, and so it's very clear to me that Americans hurt worse than everyone else in the world. Perhaps not, right? So the emerging crisis ultimately has multifaceted. Next slide, please. What we saw was what we called 3 waves of opioid overdose deaths in America. And if you could see, it's a little small up here, but ultimately it's looking at things like heroin. When we used to talk about opioids, we were talking about the naturally occurring opioids that came from the poppy fields in Afghanistan, et cetera, right? The original morphine derivatives and et cetera. But what we saw was a rise in synthetic narcotics, and in particular, very powerful narcotics, really in the teens and or 2015, 16. We saw a significant increase in them, and quite frankly, we've seen alarming issues with the illicit opioid market now, and we're going to talk a lot about that, particularly Mike will, kind of where we are right now in America. But one of the things that you'll notice is that for many, many years, and this is true in my own clinical practice, we needed to quantify all pain scales. So pain scales became the 5th vital sign. And we do believe that physiologically people don't need to hurt. And we had very powerful narcotics with the ability to treat that pain. And oftentimes those narcotics were overprescribed. And I think a lot of work has been done in North Carolina. We're incredibly fortunate to have an attorney general that has been at the forefront of this. And we've done a lot of things to reduce prescribing in general of narcotics. The problem is we had a population that was already addicted to narcotics at the point we changed prescribing practices. Next slide. So why do we have an epidemic? And the answer is there are a lot of reasons. We're one of the only places in the world that allows drug companies to advertise. We also created this pain as a 5th vital sign. We also decreased funding to mental health and behavioral health issues at the same time that we increased prescribing of narcotics. There were a number of issues that hit concurrently that ultimately created this crisis. And the way I tell everybody that I realized we had a crisis in Guilford County is in 2014, one of my supervisors called me over a weekend and said the narcotic antagonists we carried, naloxone, they were out. And I was like, we have 25 of them in supply. They said, Jim, we ran 25 overdoses yesterday. We historically ran about 5 or 6 overdoses a month, and we ran 25 in a 24-hour period, of which 7 were fatal. one of which was a pre-hospital provider, someone that did the work that I've done for a number of years, who had gotten addicted to narcotics after a workers' comp injury, a back injury, subsequently had left the profession, and then no longer could be prescribed those narcotics and turned to illicits. And as a result of that, resulted in his death. We've had a lot of change in America, and COVID, quite frankly, is the fourth wave of all of this that hasn't been well documented yet, but the social isolation, et cetera, that occurred during COVID created tremendous anxiety in our population. And that's not directed at youth, that's the population as a whole. Next slide. So I always kind of remind people, what is a narcotic? Narcotics have been around for centuries, and so they are not new. Back in the day, they were of the names of things like Percocet and Dilaudid and et cetera. Morphine's kind of the base of all of that. But I tell everyone, part of the way that Hannibal got his soldiers across the Alps is that he gave them this magic hero medicine, the hero in them, which is heroin. So they smoked heroin and did not feel the pain and were able to transcend. And so that's really goes back, obviously, to the 12th and 13th century. With that being said, narcotics do not eliminate pain, and I think people have a real misunderstanding of that. What they do is that they blunt the sensation of pain. The origin of the pain remains, and so there is a place for narcotic prescribing, and let me be clear about that. Any of you that have had a kidney stone, there is a place for narcotic pain control. I am a kidney stone sufferer. If you've ever had an open fracture, there is a place for narcotic pain control. The issue is the dose effect of multiple days, weeks, and or months of that particular narcotic. And there are people that still require long-term management of pain and painful conditions using narcotics. That's not what I'm talking about. I'm talking about my children getting their wisdom teeth extracted and being given 30 days of Vicodin when they left the oral surgeon. That was not necessary. And in fact, I went home. My wife said, "What did the doctor give you?" I said, "They gave me the prescription for an antibiotic and Vicodin." And she said, "Well, go get them filled." And I said, "Well, I'm going to get the antibiotic filled. I'm not going to fill the narcotic." She's like, "You're a mean dad." I'm like, "No. If our children need 30 days of narcotic post-extraction, we went to the wrong dentist." Right? And so knowing a little more about what was in that background probably gave me a bit of that insight. Next slide. So if you reflect back, what happened when Dorothy and her friends went through the poppy field? They fell asleep, right? No, they got stoned. And so you'll never look at that movie the same way again. Dorothy was shooting smack. No. But that being said, that's the imagery, and again, poppies and et cetera. But really, the manufacture of the naturally occurring opioids has been dramatically impacted. The majority of that was in the Middle East. Obviously, a lot of war efforts over there over the last several years has destroyed that. It's now the synthetic market that we fight against each and every day. Next slide. So again, if we look at pain as the fifth vital sign, you'll see a huge spike on that particular chart that kind of shows where narcotic prescribing went. This was back in the early 2010, 11, 12 range, and that really kind of started this issue that we had with opioids in America. Next slide. And it also all begins with our kids. And one of the things that we're going to talk a lot about is about adverse childhood experiences and other things. But I want to advance to the next slide. This became personal for me in 2015 when one of my neighbors who lives in this neighborhood died of a heroin overdose. A great kid, a kid that everyone wanted to be around, but got tied up with the wrong substances. And his parents have been very, very active in the recovery community ever since his death. But every death from a narcotic overdose is preventable. And that's one of the messages I want you to hear clearly today. Next slide. So if we go through adverse childhood experiences, there's a child risk behavior survey that's done through the North Carolina Education Alliance. It's done every 2 years. It is insightful for what your kids and grandkids are doing, and something that I recommend that people go out and look at some point. Next slide. I also want to give you a bit of insight that the younger people are prescribed narcotics, the more opportunity that they develop issues with addiction and reliance on those narcotics as they move through their lives. So if we give opioid naive folks narcotics early in their life, in their teen years, they're 3 times more likely to abuse them in adulthood. So again, something to think about when your doctor or dentist prescribes you 30 days of Vicodin for your children. Next slide. Ultimately, if we look at 1 and 3 year probability of someone ending up with addiction, if we give somebody 5 days worth of a narcotic, so basically 20 pills or perhaps less depending on the dosing, they can have up to a 5 to 10% risk of long-term addiction issues. But if you give somebody 30 days worth of a narcotic, 40% of those folks will battle with addiction issues trying to come off of those narcotics at the end of that dosing interval. And this is well-documented science, things that now every prescriber knows, thanks to the efforts of our Attorney General. Next slide. Melissa will probably hit on this and the amygdala and the importance of the brain and brain neurotransmitters, but ultimately narcotics stimulate the brain in a way that nothing else really does. And that's what the brain becomes used to, and that's where the addiction comes from. This ultimately becomes an issue that is a neuroscience issue and a chronic medical condition issue, not an issue of lack of moral turpitude, etc. A lot of people see addiction as a moral failing. It is not. It is based in medicine. Next slide. We'll continue to advance. This is deaths in North Carolina. Unfortunately, they continue to rise. This is something we hoped we had put some downward pressure on, but unfortunately, they continue to go up. Next slide. I'll go ahead and advance. Next slide. These are our overdoses this year in Guilford County. So we've run over 1,000 opioid-specific overdoses since January the 1st of this year that required paramedic-level intervention. This does not account for folks that were reversed without a public safety response. But you'll see that those overdoses are really county-wide. They're concentrated in the cities of Greensboro and High Point, as are our populations. But we can go to the most remote portions of the county and also see the same type issues. Next slide. So we're part of an opioid action plan. Part of what we do is educate, like we're doing tonight, but also distribute naloxone and other harm reduction measures that the rest of the panelists will discuss as we kind of move through tonight. This is Guilford County specifically. This is the number of patients that we treat annually since 2014, number of deaths, et cetera. And unfortunately, this year we're at about 125 deaths so far this year that are opioid related. Unfortunately, it takes about a year for the Office of Chief Medical Examiner to get that information to us. Toxicology right now is delayed. It's taken somewhere between 3 and 6 months to get final autopsy results on a decedent. But ultimately, we administered over 1,400 doses of naloxone to well over 1,000 patients last year, and we're actually going to break that mark again this year, and that's tragic. Next slide. This is the why harm reduction. We're reducing the number of fatal overdoses that occur per overdose. So back in 2017, 18% of the people we contacted ultimately died of an overdose. We reduced that to about 10%. Through the efforts of harm reduction, and we'll talk about that in just a moment. But ultimately, with the pandemic, we saw those numbers creep back up. We're hoping to continue to put downward pressure on deaths in our community. When I tell people what I do for a living, I reduce mortality and morbidity in this community. That is my goal. So we use a drug called naloxone, or Narcan, and we brought some with us today, but ultimately it replaces the narcotic on the mu receptor in the brain. That is a central nervous system depressant. It removes that, kind of like removing the key from a lock, and it plugs that lock so the narcotic cannot get back into that receptor site. It only works on narcotics, so it only works on opioids. It does not work on any other type of drug, so therefore it's very specific. It really has minimal side effects, and it really has almost no risk associated with the administration of it. It's why we want to put it out in the hands of the public. I carry it with me in my personal car all the time. I don't walk into a public facility, particularly a bathroom, without looking to make sure there's nobody, that is in distress. because people have a tendency to use where they purchase, and oftentimes that's in places like gas stations, etc. So I carry it with me all the time. Next slide. It's simple to use. A number of folks will have what's called a nasal atomizer. You just simply place it in the nares. You place and push, and it's that simple. Very simple to use. There also is injectable, etc. Next slide. So peel, place, and press is the simple instructions. It's so simple a cop can do it. Spoken as a career paramedic, okay? And in fact, one of our largest reversal agents now is the police departments. They often arrive on drug overdoses before we do, so they often are the first people to give naloxone before our arrival. Next slide. And that's me.
All right. Well, I am Melissa Floyd Pickard. It's nice to see all of you. And I don't have as many slides. I'm going to talk more and just kind of some clinical and case study type stuff. So if I could have that first slide up, that'd be great. Okay. So this is a theory of addiction, basically. It's also a theory of diabetes, theory of mental illness. And so the idea being that it's called a stress diathesis model. And the idea is that, nobody can really say this causes addiction. This one thing causes addiction. Once somebody has an addiction, it becomes less important about what caused it. It becomes very important about what to do about it. So I wanted to kind of give that disclaimer before we started talking about this stuff. Also, it's no place for shame or blame around why somebody ends up addicted for the family or for the person who ends up addicted. So these two different cups show, so look at the blue, and the blue is basically like genetic material. So the blue is things like, alcoholism runs in the family, maybe, all the other traits, because we know that addiction is multi-gene. It's not just one gene. It's about lots of different genes. It's about impulsivity. There's all different pieces to it. And so one person, the person with the overflowing cup, may have more genetic ammunition, basically. But if they didn't have stress is the pink. And stress, I'm using it very broadly here, and we're going to break it down a little bit about what the stress is. If they had the same amount of stress, both of these have the same amount of stress. The issue is that the person with the higher level of genetic material is not starting from, and they're not starting from an equal place. And this is really powerful when you think about choice and addiction. It's because when somebody who subsequently becomes addicted to something, they can remember the first time they got a high or a buzz off of something, like the clarity that most people remember their first sexual experience, with that kind of clarity. Because it's the first time, Tennessee Williams talks about a click that happens. It's the first time that things are finally okay. There's been this maybe deep unease, and it's the first time things are okay. Somebody who's not going to get addicted doesn't have that. So it's not like you're kind of comparing apples to apples when somebody who doesn't have it says, well, why can't you just stop? I've done that, and I didn't think it was that special, because it doesn't do for them what it does for the person who then becomes addicted. So I think that helps sometimes with compassion. But I like this because it just explains some of the pink. So the pink are risk factors, basically. So the environmental risk factors. So blue would be nature, pink is nurture, all right? So the pink, and this is where adult adverse childhood experiences come in. So have you heard of that before? And it's an acronym called ACE. So it's things like, violence. There's lots of different adverse child experiences, and there's lots that aren't listed. Moving is getting more attention as an adverse child experience, moving multiple times, especially multiple times within a year, especially as an adolescent. So there are just lots of different things that go into it. And that is where we can make some intervention. We can't intervene at this point much with the genetic piece, you know. We can intervene with looking at the environmental factors and then also looking at protective factors, which I think is really important. And as a parent of 2 children and as somebody whose family is through the years has been very impacted by addiction, I've always been really interested in protective factors. You know, because it's like there's 2 kids. One turns out this way, one turns out this way, you know, and I don't personally think either way is a tragedy, you know. I mean, there's different paths. However, it's interesting, we haven't learned as much about what protects people. So some protective factors with addiction are open communication, you know, families, less adverse child experiences. I thought this was an interesting one, firm expectation about that you are in trouble, like, you know, which I thought was kind of interesting because you'd think that it wasn't the same. You'd think that if you're communicating and you're really open, you know, that maybe that wouldn't be a protective factor. But if the kid needs to know that they come home with opioids, they are in trouble. All right, you're going to talk to them, you're going to do all your stuff, but that's breaking the expectation. There's a consequence. So I think that's an interesting one. Family rituals is very protective. So, dinner, vacations, church, things that extracurricular activities, positive adult people in their life. So lots of things that you would think are common sense, but that get impacted, especially when you look at poverty and you look at all the things that can happen to us when we're growing up. So next slide, please. All right, and so I think this is important. Trauma is particularly important for understanding addiction. So trauma can be lots of different things, you know. So, but trauma truly is the gateway drug. You know, we talk about marijuana being a gateway drug. Trauma really is the gateway drug because people are in pain. That's why people use things that take away pain. Yeah, and so thinking of it that way helps to make it more of a medical concern, I think. Next slide, please. All right, and so I've got these things on here to remind me to talk about them, and I've left you some links to TED Talks, which we're not going to watch because we don't have time, but I would encourage you to watch start with the one on the bottom that is Everything You Know About Addiction is Wrong. And this is Johann Hari, I think is the way you say his name. And so what I like about this, and I'm going to talk to you a little bit about the premise of this, the idea is that connection is what's missing for people who begin to use problematically. So it's not so much that the opposite of addiction is sobriety, which, you know, the absence of substance. The opposite is connection. And so, you know, we all heard of the experiment where the rats kill themselves because they drink so much cocaine water, right? So if you've heard of that experiment, you know, the idea is that if you put anybody in a cage with cocaine water, you know, they're going to just drink as much of it as they can. It's this idea that addiction is inevitable, and you know, physical addiction may be inevitable. You know, if you're somebody who is in a really bad car wreck, for example, and you are going to be taking opioids for a long time, there will be some level of physical addiction. But when we talk about the phenomenon of addiction, where someone is consumed with it and they are losing things in their life because of it, they're chasing after the first feeling, that type of addiction is a psychological addiction and usually physical addiction as well. So there was this guy who said, you know, we're going about this the wrong way. You know, we're putting rats in this empty cage, and then we're giving them the choice between regular water and cocaine water. Of course they're going to pick the cocaine water. You know, they're bored. They don't have any friends, you know. And so they decided to design this beautiful rat cage, and it was like a rat park, right? They had, you know, cool toys. They had plenty of food. They had plenty of water, plenty of cocaine water. They had plenty of friends to have sex with and be social and all this stuff. And those rats did not use problematically. And so I thought it was just a really interesting, and the articles talk more about it, but I liked that a lot, because it's, especially the folks we see in GC Stop a lot of times, we're working with a lot of people who are outdoors and who are needing everything. They don't have a lot of good stuff in their life at all. So I think that is helpful to think about. And just the idea of connection. And especially as families, a lot of what we've heard over the years is this tough love. And I did mention consequences, but I in no way am saying you should kick your kid out of the house if they come home with opioids. So because the idea of connection is what is going to help and what is going to buffer with the person helping to support their recovery. So I imagine we'll have some questions and stuff about that as we move on. But these are just some resources, and they will take you to other resources if you follow. And I think I got my 2-minute signal. I think that was my last slide, wasn't it? Is that my last one? Yeah, okay. All right, so I will pass it to my colleague.
Yeah, sure. No, whatever makes you comfortable.
You want to walk around? Oh,
I'm
he's going to do a TED
I'm gonna
Talk.
walk around. I'm gonna walk around. So, and you can advance to the first slide if you don't mind, and then I'm gonna just divert from my entire first thing that I had planned. I'm curious, did anybody drive here today? Everybody drive. I don't know if you've ever heard this before, but operating a motor vehicle can be a little bit dangerous. Right? Does anybody know anybody? Has anyone here ever been in a car accident? Seen a car accident? Right? And I won't ask you to raise your hand for this one, but my guess is that if I ask the folks here tonight if you know anyone that has passed away in a car accident, probably more than half would raise their hand, right? And so I use that analogy when I talk about this idea of harm reduction that Jim kind of introduced. And that's fundamentally what GC Stop does. That's our approach to intervening with folks. Has anybody driven a Chevy Nova before? See, really? So in 1977, I'm going to share my age and all that, but I was a little baby, and I was in the back seat of my parents' Chevy Nova, and it was yellow, and they had it forever, and it was amazing because it had a hole in the floor of the floorboard, and then as I got older, I'd watch the ground like pass by. Not a seatbelt, of course, the 1970s, right? No seatbelt, no airbag, no automatic braking like my Subaru has now, none of it. And I'm driving, my mom's driving, and I'm in the back seat in a bassinet. There weren't even car seats in 1977. And something happens, New York drivers, right? Somebody slams on the brakes, and my mom hits the brakes, and I tumble out of the bassinet, like hit my head on the floorboard. And I always use that really to give my mom a hard time, because anytime as I was a teenager, I said, it's because you dropped me on my head when you were driving. But now I want you to picture for just a second that there was an auto shop around the corner. You're driving this 1977 yellow Chevy Nova with not a bit of safety equipment in it, and you have the opportunity to go to that shop and have airbags installed, airbags and a seatbelt for free. Would you do it? Kind of knowing what you know now about safety, right? That additional layer of protection. And what if at that same shop they said, you know what? You know that sound that your yellow Chevy Nova has been making, that little clicking sound when you accelerate? So you know what? While you're here, we'll take a look at it for free. We'll look at it. We'll see if we can help. This is the idea behind harm reduction, right? That folks come to you for one kind of safety intervention, a little baby step to try to be a little bit more safe, take a little step towards being healthy. And then once we get you in the door, we can say, well, gosh, here are all of these different things that we can do, right? We can offer airbags and automatic braking and these great seat belts. That's harm reduction, right? Next slide, please. So what is GC Stop? Guilford County Solution to the Opioid Problem serves folks who have overdosed or are at high risk for an overdose in Guilford County. It's a partnership between Guilford County and UNCG that started in 2017, and I hope I'm not speaking out of turn here, but it started on a cocktail napkin at Carolina Deli between Jim and my predecessor in this role, Chase Holloman, who came up with this idea of how are we going to intervene in the with the opioid epidemic in Guilford County. So it was established in 2017, and then the first services were launched in 2018. And I'll talk a little bit more here shortly about what those services are. Next slide. So what's the mission? The mission is simple. It's to help keep people alive. Right? It's to decrease opioid-related mortality. One of the things that I've really learned in my work with GC Stop is that every single person that we interact with is somebody's son, somebody's daughter, somebody's mom or dad, somebody's sibling, right? Everybody has a story. And what we want to do is we want to help folks stay alive and take whatever steps they can to stay alive and finding health and wellness and reconnecting with folks. So what do? We engage participants, Okay, so we engage participants with those harm reduction services, and we have a whole array of harm reduction services. And I'll talk more about those here in a second. We distribute and train community members on the use of naloxone. We've brought some today. And in fact, if y'all want to grab one or two and kind of just pass those around and see, I can kind of get an idea, at least of the kit. This is one of what we distribute. These are intramuscular naloxone kits. Sure. Welcome to open them. And then what we do, remember that part with the Chevy Novas, where not only do we install the seatbelts, but we also listen to that sound, that little clicking sound that the engine's making. We offer case management, counseling, community resource referrals to treatment when folks are ready, if at the time comes that they're ready for treatment. Next slide, please. So this is a little kind of honeycomb of all of the different partnerships that GC Stop has, which is something that's really unique in the social work community, which is my background. So UNCG, Guilford County EMS, caring services, police departments, private donors, religious communities. So all of these different facets come together to provide support and provide referrals to us. Next, please. So the program areas that we have, this is kind of the foundation of GC Stop. This is the first arm of GC Stop that was created, which is PORT, Post-Overdose Response Team. So this is, and it's one of my favorite parts that I kind of nerd out on a little bit, is that when Jim's folks, when the paramedics respond to the scene of an overdose, say they reverse the overdose using naloxone, and then the person says, no, I'm feeling better, I'm really not ready to go to the hospital, the paramedics will offer them the opportunity to have someone from the GC Stop team to follow up with them. And then there's an automatic reporting mechanism initiated right there on the ambulance that generates a report that comes to our GC Stop team so that we can follow up with folks. So our goal is to follow up really next day is our goal. We say 72 hours to allow for the weekend, right, if something happens on a Friday and we're not there till Monday. We provide naloxone and overdose prevention training to folks, facilitate referrals. For a lot of folks, this is a time where they say, you know what, this was horrible, right? This was a horrible event. EMS came and police came and the fire department came. I want to do something different, and that's our opportunity as the GC Stop team to offer interventions. And that might be everything from here's how to avoid overdosing in the future to I'm ready to go to detox and go to treatment today. And no matter where someone is on that continuum, we help facilitate that. Next, please, thank you. Syringe Services Program, SSP. Our Syringe Services Coordinator, Mr. Tyler Yates, happens to be right here today with us. Our syringe service program operates on a couple models. We have fixed locations in Greensboro and in High Point, also provide mobile services, and my favorite, which is a mobile pop-up clinic where we pull up in a parking lot and put up a tent and give people cold water and naloxone and whatever kind of assistance they need. We facilitate referrals to treatment, case management, and counseling, and provide safer injection and safer sex supplies so that people can take whatever steps they're ready to take to be more healthy and reduce the transmission of bloodborne disease. Next. Thank you. So our service delivery, I touched on that picture there, is from one of our more recent pop-up clinic sites that we had. This is one that we did at Compare Foods on Summit Avenue. The folks in the back are our GC Stop team. We have several full-time employees, but most of our workforce are interns from social work, Bachelor of Social Work and Master of Social Work programs. And my amazing intern, Morella, is here to say hi to you all today as well. And then in the front is Nurse Victoria. We have a partnership with the Cone Health Foundation. And Nurse Victoria is a congregational nurse that comes out on the pop-ups with us so that if someone says, hey, can you have this rash? I don't have to look at it. I can say, here's Nurse Victoria. Next. Our hepatitis C program, this is an initiative with the health department, hepatitis C and HIV testing. This is really cool and has evolved over the course of the last several months at these pop-up clinic sites. We'll do blood draws right there. We have 2 phlebotomists, Tyler's one, who if somebody says, you know what, I'm interested in getting tested for hep C or HIV, we can say, well, great, here's a form, let's have some blood, and facilitate that process. We provide linkage to medical care if they come back as hepatitis C or HIV positive, and then, again, kind of the cornerstone of what the team does is case management and counseling. Next. And then finally, our Justice Involved program. We have a Justice Involved coordinator, as well as several interns who are embedded in the Greensboro and High Point detention centers. Sadly, a lot of our response as a community, we talk a lot about how substance use and mental health issues are a medical issue, but we also lock people up for that medical issue, right? And so now all of a sudden they're incarcerated and they're going through detox. It's also a great time for GC Stop to pop in and say, hey, let's help. Because when someone is released from jail or from treatment, their risk of suffering a fatal overdose goes up 14 times. Tyler's going to correct me, 44%? 40 times. 40 times within the first 2 weeks of being released from the abstinence-based program. Right? Yep. So that is GC Stop. We have, I think, some handouts and things that have a QR code for us. Also brought some flyers, but really encourage you to feel free to reach out or have folks reach out. A lot of the referrals that we get, in fact, a lot of the ones that come right to me, are folks who say, you know what, my son or my brother or my neighbor, those types of things. And so help us connect with folks.
Okay. So before I start, I want to point out the banner that's back here. One of the things that I do now is I work with an organization abbreviated in CAPDA, NCAPDA, the National Coalition Against Prescription Drug Abuse. And since 2017, we have hosted the International Overdose Awareness Day event in Raleigh. We just had our 6th annual event, August the 31st. It is a kind of a multi-purpose event. First, it is an opportunity for families and loved ones to come together and honor their loved ones that have been lost, but to be there for each other and support each other. So first, it's a memorial event. We have a candlelight at the end. And then second, it's also a time to encourage people that are in recovery or seeking to be in recovery and to provide resources to anyone that's there. This year we had almost 25 resource tables at the event. So, but that banner, those are all names from North Carolina. The names are submitted. They're not over a particular year or period of time. The names are submitted every year. The youngest person on that banner is 5 years old, and the oldest is 72, I think. I did not look at ages this year, but so that gives you an idea of the impact. The median age is actually about 24. So now I want to introduce you to my daughter. Sorry. Let's just tell these guys, this is the first time I have told our story in probably 3 years. And I had gotten to the point where I could get right through it without breaking up. Sorry. Thank you, Craig. So this is Vanessa. And you've heard it said that a picture is worth 1,000 words. Well, that's a long book. And it's a story about someone that loved everybody and everything unconditionally. And she believed that everyone deserved to be treated with respect, no matter what. I'm referring here for 2 reasons. One, because I'll probably talk for 2 hours if I don't. And second, I want to make sure I don't forget anything important. But I tell people all the time that I truly believe Vanessa could have taken a lion or a tiger or a rattlesnake and they would have immediately in. And that was her. She just loved everyone and everything. She was 4'11", I don't know, maybe 98 pounds. But her heart she had the biggest heart of anybody that I've ever known. And that's actually where her struggles began. Because she loved everybody so much, she thought everybody else should love everybody that much. And when she didn't feel that love coming back to her, it hit her really hard and really deep. So it actually started in high school. Well, there's one I wanted to make first. To things affecting her deeply. 9/11 was one of those things, and we were talking about adverse childhood experiences. When 9/11 occurred, I traveled every week for a living at that point. I covered the entire East Coast And all that, my kids really paid attention to was that on Monday morning, Dad got on a plane and flew away, and he'd either come home Thursday night or Friday, and they typically didn't know where I was going. Well, on 9/11, that week I was actually supposed to be in D.C., and my appointment had canceled on me on Friday. And I rescheduled my trip, and I drove to Augusta, Georgia instead. When everything happened, Vanessa was sitting in school in the library, and they had the TV. Why they would have done that, in hindsight, I think they realized that that probably wasn't a good idea. And she was inconsolable until they could get me on the phone. And I drove straight back to Augusta. But that hit her so hard and so deep. For months after that, we discussed why people would be that mean, why things like that would happen. And I honestly believe that stuck with her the rest of her life. I have no doubt. To give you more on the type of person Vanessa was, if she were riding around and she had the money herself, and she saw a homeless person standing on the street with a sign collecting money, she'd go buy their lunch. She wouldn't just give it to them, she'd sit down and eat with them. And that was her. She would sit there and have a conversation with them. But because of all those deep feelings, she started self-medicating when she was in high school. As parents, we now realize, and very quickly realize, that we did not know what we did not know. And we made all the assumptions, that, she's experimenting, she's doing the things that kids do. Those are dangerous, dangerous assumptions we know now, of course. But by self-medicating, it was a way that she could feel like she was a part of things. She was in a crowd. She was with a group of people that she thought were her friends. And they were. They were all trying to get through the best way they knew how. There was a study done, and I looked for the study again today because I wanted to go back and verify the numbers, but I'm going to summarize the numbers here. There was a study done, it's been a while, of people who suffered from a substance use disorder on when they started their first interaction with substances. Over 90% started before the age of 18. Over 60% as early as middle school. So this is, and when I heard this statement by someone else the first time, it really took me by surprise. This is a pediatric issue. It's not just an adult issue. Next slide, please, Barry. That is all faces from Guilford County. That's 27, I think, is what they fit on the slide. And I could have had 200 probably on there. But I knew that it was getting full, and you probably wouldn't be able to see it as it was. But, that, my daughter's in the right corner. The young man that was talking about is bottom, second on the left. And, there are others that are on that band that some of you know. So after Vanessa graduated from high school, she went off to college, UNCG, and was so excited to finally be going after her dream of becoming a counselor and being able to help people that had been through some of the same things she had. Vanessa had been horribly in middle school, and not so bad in high school because she found a group that she felt comfortable with. But she got to college, and what we thought was her just really becoming more into a party life really was more than that. So, I'm sorry. The lady who just left, her son, is on that collage banner. This is hard. So anyway, her grades started failing, and all the signs were there, but we didn't. Again, we just thought, it's college, right? Well, we found out otherwise in the middle of the night in 2012 when we got a phone call from the emergency room at Wesley Long Hospital. And there was an ER said, "We need you to come to the hospital, to the emergency room. We have your daughter here." And I'm like, "Well, what's going on?" And they basically hung up and said, "You need to get here." When we walked in the door, the ER doc said, "We've got her back." And I said, "Wait a minute, what do you mean?" And he said, "We got her back, but she was, medically when she walked in, when they carried her into the emergency room, they were able to revive her, and she was on life support." And said it'll be 48 hours before we know, all the effects and what might have happened. And about 6, she was able to come to life support. Right after that, she was a different person, and we thought that was the wake call, that was the answer. Well, that's really when the roller coaster ride began, and for the next couple of years, it was up and down, all over the place. Then late in 2014, Vanessa came and said, "I can't do this to get my life together and to start to chase my dreams, start to do things. Can I?" So yes, we let her come home. Thank you. Barry, you got the other one down? All right. So I had turned her bedroom into my office, so we turned our den into her bedroom. And for about 5 months, she slept on a mattress on the floor in our den and was so sick. And I thought she had the flu. And what I know today is it was severe withdrawals. I didn't know that. Not at that time. After about 5 months, she had this positive outlook. When Vanessa came home, she was so thin, so skinny, and so small. And she had put her weight back on. She was smiling and happy again and dreaming. She had her dreams all lined up and back in order. And she was excited about life. And she told my wife and I, she said, "You know what? I have left all my old friends behind, and I have met a new group of friends, and I feel more positive about life than I have in a long time." Well, we never met any of those friends until the day that I stood right here and gave my daughter's eulogy. And one of those friends thought that it would be a really neat idea for them to do heroin together. And by the way, that was what my daughter had overdosed on in 2012. And it didn't turn out so well. January the 31st of 2015, we got a knock on the door, and there were two detectives standing on our front porch there to tell us that our daughter, 24 years old, had died of a suspected overdose at 9:12 in the morning. They didn't come find us to tell us until about 2:30 in the afternoon. Why we weren't on social media that day is a miracle in and of itself, because it was already being posted about on social media before we ever knew about it. So as a family, before all of this, we were lost. We didn't know where to turn. We didn't know what to do. We didn't know how to go about finding out. And they say hindsight's 20/20. Well, I'm not so sure that's even accurate right now, because every year, every day that I go through this, I learn something new. So I'm going to take a quick peek at my notes here to make sure I'm not forgetting anything that I wanted to cover. So since her death, I mentioned standing here and giving her eulogy. During that eulogy, and Butch was officiating the service, and he may remember this, but during that eulogy, I was very open about what had happened and the fact that Vanessa had been involved in substances. I also made the commitment that day that I would learn everything I could, that I would get involved, and that I would do everything I could to fight, this overdose crisis that we're in. And that's what I try to do. And what I would ask everyone to think about and listen and try to do themselves are a couple of things. One, learn everything you can. Two, if you suspect that your children or your grandchildren or your great-grandchildren may have an issue, don't fight with them. I made that mistake. I fought so hard with my daughter, and that did nothing but push her away. But be there. Just be there. I've started binging on NCIS, and I don't know if anybody's familiar with the show, but there's one character in the show who finds out that his daughter is addicted to opiates. And they're fighting, and then somebody advises him to stop fighting and just be there. And there's this one scene, I just watched this a couple weeks ago, there's this one scene where she's just in his face, and she's blasting him, and she's just, get out of my life, you don't know anything about me or my life. And he doesn't say anything. He just opens his arms. And I saw that and I thought, wow, really wish I had done that. So, today, I do everything I can, and will continue to do everything I can to help those that are suffering from a substance use disorder. Mental health challenges certainly played into my daughter's path to addiction. But there are things that we can do as a community and as families that will make a difference. In the anthem video that played at the very beginning, you saw the piece about disposing of your medications properly. So drop boxes are great, and there are a number of drop boxes in Guilford County. Do you know how many, Jim? How many? Okay. But another convenient way, and I brought up, there's a container of these outside as you're getting ready to exit the church. You'll see them. Please take as many as you'd like. This is a medication disposal kit. If you have unused medications, it doesn't have to be opiates. It can be over-the-counter meds, it can be prescription meds, liquids, films, whatever. This packet will hold up to 90 pills, and everything's explained on the packet and on the flyer on the back. You open it up, you dump them in, you add a little bit of water, you let it sit there and do its thing for a few minutes, and then you seal it up, you throw it in the trash. Completely biodegradable and safe, and it deactivates the medication. You know, you'll hear people say it's okay to flush them. I never tell people that. I don't want it in the water supply, you know. But you'll hear things like coffee grounds or kitty litter. Someone who suffers from a severe enough substance use disorder will go through the kitty litter and pull them out if they have to, if they are in withdrawals enough. And that's a sad thing to say. And it's probably stigmatizing even more, but you have to understand what a severe substance use disorder really is. And a grief group that I used to go to, there was a lady who told a story about her son, and she said that her son explained it to her this way, that if they were sitting in their den and on the coffee table was whatever drug of choice it was, and whoever was there said, "You can have that, but it's going to kill you," I'd still take that chance. That was the way he explained it to his mom. So it's powerful. Would you mind holding that for me a second? So we talked about Narcan and naloxone. There are a number of different types of naloxone. I'm going to open this one up. I forgot my trainer, so I'm going to go on and open this one, and it'll go in my kit. This is the nasal Narcan, okay? Now, this one, Tyler and I talked about this earlier. Mike and I, or Jim and I haven't talked about it. This one right now has a little bit of controversy in the market. And the reason this one does is because it's double strength. It's 8 milligrams. Normal Narcan is 4 milligrams. When you administer Narcan to someone, it knocks those opioids off of the opioid receptors in the brain. And by doing that, it will also throw them into some level of withdrawal symptoms, which can be extremely uncomfortable. So the 8 milligram is a little controversial right now because people are curious that it might be overkill. But what we're seeing with the fentanyl that's coming into the illicit drug market is that it's taking 5 and 6 doses sometimes to pull someone out. Now that's rare. But at the event in Raleigh, the person who did our Narcan training told the story that it happened the day before. They used 4 or 5 nasal Narcans and 2 intramuscular to reverse an overdose the day before. And it was fentanyl. So this is the nasal, and it just put it in the nose and the nostril and spray it, 1 pump, and that's it. And then you wait. I don't know, where am I on time, Nancy? Over? Thanks for the warning. How quick can you do just a quick run through of a Narcan training with just how to check for an overdose and how long you should wait? Or Tyler, can you do it? Come on, Tyler. Come on, just real quick. I think this is important, so.
No, I don't need the mic. Can y'all hear me? Cool. Super easy to use. Saw it up on the slides earlier. Pill place press. So these kits have a little tab on the back. To check for an overdose, the first sign you want to check for is if somebody's breathing or not. A lot of times if somebody's overdosing, there will be other signs that, it's an overdose. There may be a needle or some drugs around, a straw, something of the sort. but you'll take it out of the pack, simply place it up the nose, and press the button. I'm not going to press it because there's naloxone in this, but just press it one good time. It administers the entire dose. You'll wait 2 to 3 minutes and then administer the second dose. During that time, it's very important that you call 911. It's a lot of people have this fear that if you call 911, you're going to be in trouble. North Carolina has a Good Samaritan law that protects those that call 911 in response to an overdose. So if you were to be in possession of any type of, opioid or cocaine, up to a gram, you are protected. So,
Yeah. Talk about the sternum rub.
yeah, and while you're waiting, one thing that you can do to try to help bring the person back is to give them a sternal rub. Take your knuckles, rub really, really hard in the middle of the chest. It does not feel good, and if anything's going to help bring them back, while the naloxone is working on those receptors, it's going to be that. It's also really important to make sure that the person's receiving oxygen, so providing rescue breathing, giving one breath every 5 seconds is super important. That just kind of keeps the oxygen going through the body as you're waiting on more assistance.
Good deal. Thank you.
You might want to hold this. I put it in my nose.
Here, take the other side too.
Sorry.
There. All right. So those are things that we can do. Carry naloxone, dispose of our medications, learn what you can, and combat stigma. And of all of those, stigma is probably the one thing that I would say we have to get around. And it's also probably the toughest. So I'm way over, as Nancy said. Tons of things I could say, but I'm going to stop.
Thank you, Randy. Before we go on, let's just give a round of applause to our panelists. Thank you for the incredible resources. Randy, thank you for the powerful story. We do have, if any of you have any questions, I've got a couple that have been submitted up here. Nancy or Butch, if you'll gather those. We've got a couple of intro questions, and then we'll try to get through these in the time that we have with us. All right, so let's go back. One of the things that I think, Jim, you talked about in a slide was the presence of the synthetic opioids, and fentanyl is clearly one of those. One of the questions, how do I, as a citizen, as a parent, as a relative, what does fentanyl look like? How do I know that I'm working with or looking at that?
Realize that the fentanyl that I administer on the ambulances is fentanyl citrate, and it's from U.S. Pharmacopoeia. We buy it through the pharmacies, etc. We generically talk about the illicits as fentanyl because they are derivatives of that. So first and foremost, if you get it at Gate City Pharmacy, you're probably good. If you buy it out here on the corner from somebody who happens to have some fentanyl for you, question what that particular fentanyl is. And that's what we're seeing. It's a crystalline powder. Most of the fentanyl that we see, however, we're seeing more and more of it compressed into counterfeit tablets. So again, the whole issue is it may look like an oxycodone. And it looks like an oxycodone that you've had before, but in reality it is not. And so typically this audience isn't going to be buying that particular narcotic on the street, but that is where in our high schools and et cetera, it becomes a major concern when they buy a tablet for a party this weekend, et cetera. There's no telling what's in it. The most lethal that we're seeing right now has a purplish hue to it, but this crystalline powder can very easily be snorted. It is not always injected. I think when we think of heroin and we think of fentanyl and et cetera, that people are using IV drugs, most people as their gateway are able to snort it, and it's a white crystalline powder, maybe with a little grayish hue to it, et cetera, but nothing that really would be striking. In fact, I will tell you our cocaine market is so contaminated right now that we ran 4 overdoses at the same time at the same residence with people that had never used any fentanyl in their lives, however, on a Friday night had bought some cocaine and were sharing it among the group. We resuscitated 2 of the 4. 1 did not make it, and the other didn't as well. So we lost 2 of the 4 in that particular case. It was almost pure fentanyl. It was not cocaine. It was just a Friday night. We're going to go off, blow off a little steam, etc. No stigma associated with them using recreational drugs, but ultimately that use killed 2 of the 4. They were 19, 21, 24, and 26 years of age. So don't buy from anybody but, Walgreens, etc.
Thank you, Jim. Now, to run with that, and Randy, you talked about this a little bit as well. What are some warning signs that if somebody in our family, somebody that we're close to, may have a concern with opioid use? What are some things that we should be aware of and looking for?
Again, it just goes back to being aware and being open and being present. Vanessa was not, she was not addicted to any one drug, I don't believe. She was looking for whatever made her feel better today. And that was how it began. And she was being prescribed a couple of medications for anxiety. One is a medication that is highly abused. And her doctor kept filling it, even though she had been seen, and we didn't find this out until after she died, she'd been seen in the emergency room multiple times for overdoses on this particular medication. We didn't know that until after the fact, and that's why I don't like HIPAA laws, but we won't go into that. Because it was none of our business. She was 19 years old, 20 years old when it happened. But the doctor kept prescribing it and kept filling the prescriptions, even though she had been told that my daughter was abusing it. So I think it's just being aware and trying to be involved in their life without being too intrusive.
Anything anyone else would like to add?
Yeah, I could add to that. I would also say they get angry, irritable when they're questioned about it, excessive guilt about it, then also using it in the morning, like off times, like you find that they're using before school. That can all be signs that somebody's in trouble. And then, it depends on the drug, but with opioids, you often see excessive sleepiness. But there are some folks who get energized too. The pupils are constricted, right? Mm-hmm. Typically, pupils get really pinpoint.
So when someone's under the influence of one of these substances, pinpoint pupils might be a really great way to see that. Great, thank you.
Mm-hmm. Sweets, like really craving sweets.
So let's go ahead and take that next step. If you suspect that someone is using, let's talk a little bit about how might I approach them in ways that would be more effective or less effective. And I'll invite any of you to jump in here.
So let me start by saying don't do it the way I did it for years. Butch, no offense, but I was very ministerial in my approach to folks after an overdose, and it normally started with something along the lines of, you're exceptionally fortunate to be alive, and if we hadn't been here, you could have died from this overdose. They already have guilt and shame, and they're aware of the fact that they nearly died from this overdose, but they also are addicted to the medicine that caused them to be in that condition. The most powerful thing that you can tell people is that you care about them and you love them. And, I think it starts there, and then the opportunity comes to then start the process of handoffs. I will tell you, seeking care for folks in addiction is exceptionally difficult. And you've heard the word navigation multiple times with us tonight. The reason we put navigation programs in place is that people cannot navigate this on their own. And so what we do is that we facilitate that navigation for folks through GC Stop so that they can get doors opened for them. And I'll tell you just personally, I have a coworker who has a 16-year-old daughter who's addicted to heroin. They were able to get her emergently treated. They had resources, double insured, have money. It took them multiple attempts to find placement. Their daughter is currently in a residential treatment facility in Stamford, Connecticut. That was the closest location that they could find inpatient care. And it took them 3.5 months from her near fatal overdose to find placement. It completely disrupted that family for that 3.5 months trying to keep their daughter safe. She became involved with GC Stop because she escaped from her parents, right? And was ended up a 16-year-old child living on the streets, living in a homeless encampment and using IV drugs at 16 years old. That's the power that this does. So let us help you, and lots of support, family support, your church support, other things, counselors, any and all really needs to come to the table, because there is not an easy solution that is also quick.
And one thing I would mention too, there's a great New York Times article about nobody brings casseroles when your daughter's an addict. And it talks a lot about one of the most powerful things you can do as a church and as a community is to wrap around the families where this stuff's going on, and just knowing that they can talk about it, that they can talk about it, and it's usually not something where somebody gets their appendix out and it's over and you send a casserole one time. You may have to send a casserole multiple times. There may be jails, there may be but just the idea of the staying power of the community to support people.
Thank you. So one of the things that is clear is that Narcan is an important way to keep folks alive. And for many of us here, this may be the first time that we've seen it. As someone in the general public, and I encounter a situation, how do I access it or help somebody access it if I believe I'm going to encounter or do encounter that situation?
I'm going to jump in on this one real quick, because the first thing you need to do is not be afraid to pick up the phone and call 911. If you don't have Narcan, and not everybody does, I would encourage everybody to carry it, because you never know. I was in Biscuitville, and there was a gentleman sitting at the booth in Biscuitville that was very close to an overdose. And you never know when you're going to run into that. Hopefully you never do, but you never know when you might. But calling 911 is the single most important thing anyone can do. And in my daughter's case, that didn't happen. They panicked, and they did not dial 911 immediately. We found out just by coincidence. While my son was in school at UNCG, he had to go to the campus police department, and started talking to one of the officers just in conversation. And somehow or another, the subject came up of overdoses. And he said, yeah, my sister overdosed. And the officer that he was talking to had been the first person on the scene. And we know now from that conversation that the amount of time it took for her to get there from the time the call was made, had they called immediately, there may have been a chance that I wouldn't be sitting here today. And I was going to say this at the end, but I'll say it now because I've kind of set it up. So Tyler mentioned the Good Samaritan law. North Carolina's Good Samaritan law, unfortunately, is about the second worst in the nation as far as what it provides for protection in case of an overdose. So I am a part right now of an organization called Expand Good Sam NC. And that's our goal, is to expand the Good Samaritan law. In North Carolina, there's what's called a death by distribution law, which almost negates the Good Samaritan law in North Carolina. There are still some protections, but people panic and they don't dial 911, and that's costing lives.
Jim, I saw you nodding your head vigorously.
Yeah, so obviously I am 911, so call us early, call us often, and law enforcement, fire, and EMS are all carrying naloxone. So anybody that shows up from public safety response has the ability to recognize the signs and symptoms of an overdose. We have the ability to breathe for someone that didn't breathe in on their own, and we have the ability to deliver naloxone. What we see is kind of this indifference of society, where if you kind of turn your head, it'll go away. If the guy's falling asleep at the booth in Biscuitville, somebody needs to do something. So just simply see something, do something. I can't tell you how many deaths we run in a vehicle in a parking lot where somebody's like, oh, I parked next to that car and I thought the guy was just asleep. And I realized that there's now fear in society, right? You knock on the window, somebody pulls a weapon on you, you just don't know what's going to happen. But in reality, do something, call us. If you're not comfortable knocking on the window, that's fine. We'll come and do that for you. And if we need to, we'll knock that window out. So, we're good with this kind of stuff. And so please do something.
Yep. I just want to mention real quick, in terms of folks wanting naloxone, call us, call GC Stop, text us. In terms of the community or places of work, places of worship, invite us to come to your health fairs and we'll set up a table and give it out and teach people how to use it. It's a great thing to have. I think it should be in every single first aid kit. And I think that one of the most important things that we can do is to reduce the stigma associated with that. I have naloxone in my personal first aid kit. I taught my kids how to use it. It's right next to glucose tabs. And so I think fighting that stigma is really helpful. And even though, we talked about the signs of how somebody may have an issue with opioids or any kind of drugs or alcohol, one of the things that I've seen is that there are a lot of folks who are maintaining really, really well, right? They're employed full-time, they're driving, they're taking their kids to soccer practice, they're doing their thing. So I think having an open relationship where you can talk about these things, where you don't sit at Thanksgiving dinner or Christmas dinner and talk about those people, because we never know what those people are around us. And that's what I try to do in my own family, is to just have enough of an open dialogue that hopefully anyone would feel comfortable saying, hey, I'm losing a little control here.
Great, thank you.
I asked that question. Can I read something, an article that I found? This shows how we have evolved with our own personal thoughts about Narcan, opioids. I saw this headline that it said the Forsyth County Sheriff's Office put a Narcan vending machine in their detention center lobby. And I thought, my gosh, why would a sheriff's department enable people to do illegal drugs? So I thought, maybe what I should do is read the rest of the article. So I did. And it says, and this is the quote part, and Jim, you mentioned this, part of the reason we decided to have this machine placed is because of a study that was done recently by UNC Chapel Hill that found that people who are leaving an incarceration setting are about 40 times more likely to overdose than the general population of people. However, they also said that those leaving incarceration are at the highest time of risk in overdosing in the first 2 weeks that they are released. And the person ended the article saying about a person that works with the behavioral sciences, we do know, unfortunately, they're probably going to go back to using a substance and then having Narcan to save their lives, and that's valuable. So I kind of morphed from thinking they were enabling to they are now saving. And that was a huge impact on me. Because I thought they were adding to a problem when I realized that they are helping to heal a problem.
Right, and I actually have a follow-up to that. So Guilford County, we actually got a vending machine from the same source, and we have not gotten a final approval from the Guilford County Detention Center to put it there. So right now, it lives at College Park Baptist Church where we have our clinics, and it's sitting there. I see it, every time we go in there. But once we get approval, we're hoping to move it to Guilford County. So if anybody has any pull, we're trying to get that through.
And we have 2 detention centers in Guilford County and 1 vending machine,
Yeah,
which will be the
yeah,
next
that's the
problem.
other thing. We do. Yeah.
Well, no, we are at our time. I've got one more question that maybe, this is probably a longer answer, and maybe we address this next week. But Melissa, you talked a little bit about some of the predisposition things. We had a couple of questions come in recognizing that, hey, if I've had a child who has been in the NICU, and that trauma, or if I've got a child who has been on ADHD drugs, is there any data that suggests that those are things that I put in the back of my head as being aware of, or how do I think about some of those broader connections that may still be out there to make?
Mm-hmm. Well, I mean, those are good thoughts and good questions. I would be careful. I want to be careful, around especially like untreated ADHD is probably more of a risk factor for addiction than treated ADHD. But the kid that was in the NICU, yeah, possibly they could have higher risk for lots of different kinds of things. But it's just, yeah, I know I was hesitant. That's why I said the disclaimer, about, there's no magic kind of cure. It's just that we know that you can't keep making withdrawals. You have to put the deposits back in to the environment.
Well, thank you. Is there anything else that one of you would like to add before we pull this to a close?
There's a health department did a campaign that we are part of called Save a Life Guilford that is online that you can, and there's some really great videos about Narcan, and that tells you where you can go pick it up for free.
I also, so Mike mentioned they have some kits. I also have some of the ones that I had here as well, if anybody would like one. Yeah, I'll go ahead. I don't need that. This is working again, it sounds like. So next week, I hope that all of you will come back and encourage others to come, because next week I think both of these sessions are equally important, but I think next week we're going to dig into why and how, and that specifically is why should the church be involved in this, and how can the church get involved in this. Elizabeth Brewington with the North Carolina Council of Churches will be our speaker and presenter next week, and I encourage you all to be here. I know that we're streaming this, I think, tonight as well, so hopefully anybody that's watching this online will consider coming and being with us in person.
And so we're, one more time, thank you to these panelists. What an awesome job. And Ernie's going to close us in prayer.
Yeah, and I do want to thank them both for your time tonight. Has been really helpful, but also just the work you do is so important, and for all that you do to help folks. Thank you all for coming. Do come back. Do bring a friend. We'll also have the live stream, so we can also make that available on the website. So appreciate this. Let's look to God in prayer. God, this has been a night for us to learn. Sometimes learn some hard stuff, to hear some difficult stories, but we are glad that there is hope, and that there is a chance to save lives, that there is a chance for each of us to find a way to make a difference. And so we pray that we would take this night as a challenge and an invitation, and that you would use us to spread this word so that we might together bring healing to our community and to our world. And we pray these things in Christ Jesus' name. Amen.